The disclosures for guests on this podcast can be found in the show notes.
Hello and welcome to JCO at ASCO 2026. This is our series where we cover some of the top JCO papers published simultaneously with their abstract presentation at this year's meeting in Chicago. I'm your host, Dr. Ash Gurumurthi, JCO Editorial Fellow, and it's my pleasure to be joined by Dr. McArthur, JCO Associate Editor, to discuss the Journal of Clinical Oncology article and ASCO annual meeting abstract presentation on individualized neoantigen therapy plus pembrolizumab in melanoma. Specifically, this is Intismeran Autogene plus pembrolizumab versus pembrolizumab alone in high-risk resected melanoma with a 5-year update of the randomized phase 2b Keynote 942 study by Katak et al. Welcome to our show today, Dr. McArthur.
Pleasure to be with you.
So let's start with the relevance of the article, Dr. McArthur. Can you explain this in more detail to our listeners?
So this is a really important article showing longer follow-up of what is poised to be one of the most important recent phase 2 randomized trials in the whole of oncology. So this study looked at novel mRNA-based neoantigens derived from sequencing of patients' tumours, and then up to 34 neoantigens encoded by the mRNA that both class 1 and class 2 restricted, so CD8 and CD4 T cells, were made into vaccine co-administered with pembrolizumab in patients with completely resected melanoma. And really importantly, this was randomized to standard of care pembrolizumab alone. And so with such positive results, it's really the proof of concept that the neoantigen vaccination approach can have clinical impact. So although a phase 2 trial, not changing practice right now, it's pivotal in a new way of thinking about an approach of using personalised vaccines, neoantigen vaccines in patients with cancer.
Can you tell us a little bit more about what some of the key results are?
So being a randomised trial, there's clear comparisons on a number of key clinical endpoints. So relapse-free survival, distant metastasis-free survival, and now the study at 5 years also reports overall survival. So there is a statistically significant improvement in relapse-free and distant metastasis-free survival that holds out at this 5-year analysis. You know, it's very impressive hazard ratios of 0.51 for relapse-free survival, 0.41 for distant metastasis-free survival. And there's also a trend for overall survival, but this was a small study, so one would not expect to see impact on overall survival from this study, but really very telling results. And secondly, and you know, this is one of the things I really like about the work of the investigators, is to look at some correlative biomarkers, T cell receptor clonality, and the emergence of unique T cell receptor clonotypes as well. And they demonstrated, and this is really important data, I think, because it confirms biologically the postulated mechanism of action, that is that the neoantigen vaccines led to an expansion of T cell clones that was associated with response and did not occur in the control arm. So this is important data that biologically, through mechanism of action, is highly consistent with the clinical results.
I want to press on that. You're right. I saw that the T cell clonotype data was very interesting, with the dual therapy showing sustained clonotype expansion, even by 3 cycles of the dual therapy, and it seems to persist up to the end of therapy. But pembrolizumab alone seems to show early separation, but then it converged by the end of therapy. It's almost like that immunologic memory is just gone with pembrolizumab alone.
Yes, I would interpret those data really to show that one's not getting continued expansion with pembrolizumab alone. Clearly, there are some reactive T cells. You know, that's, of course, why anti-PD-1 therapies have their activity, but quite a significant difference in those that received the vaccine. And secondly, the fact that there was an association with clinical outcomes. and relapse-free survival. So therefore, there's an anti-tumour activity associated with that particular biomarker. So, I think that's interesting, impressive data consistent with demonstrating a clinical impact on the clinical endpoints of the trial.
Are there any outstanding questions that still left to be answered after this trial?
It's very clear that this needs to have a larger confirmatory trial, a phase 3 trial, which has completed enrolment and may even read out later this year. I think this is a very important phase 3 trial because that would be practice changing if positive. And so that's a very, very important next step. There are differences, though. This study enrolled predominantly patients with stage 3C melanoma, where the phase 3 trial incorporates patients with stage 2B and 2C disease, so primary melanomas that are totally resected, as well as those with regional and distant metastases that are resected. So it's a broader patient population. There's a difference there, but clearly would be practice changing if that trial is positive.
And what do you see as some of the strengths and weaknesses of this study? You've already elaborated that it's signal-seeking, sets a new paradigm for us, and practice-changing updates will come through a phase 3 study.
That's clearly the weakness, but, I think we need to turn around actually as a strength because, this study, not a large study, there was only just over 100 patients randomized on the vaccine arm and 50 on the control arm. But the strength actually of that approach has been to give an actual clear signal that has really ignited the field. And this has application beyond melanoma as well, because there are neoantigens encoded by single nucleotide variants encoding regions in, a wide number of cancers. One might not need a very large number of neoantigens to get a clinical response. So this has got implications beyond melanoma. So that's a strength. The only real weakness to me is somewhat narrowed patient population, really enriched with just one stage of disease, stage 3C, and the fact that it's not yet poised to immediately change practice. But of course, that will come with the phase 3 trial.
And let me ask you, the paradigm in melanoma has changed a little. There's been neoadjuvant therapy in stage 3, and this is a form of adjuvant therapy. Do you think we could eventually integrate this into a neoadjuvant approach if we have confirmatory phase 3 studies?
Yes. So in terms of the impact on practice, if the phase 3 study is positive, that must fit into the paradigm of neoadjuvant therapy, because neoadjuvant therapy where the immune checkpoint blockade is superior to adjuvant therapy in melanoma and has rapidly become a standard of care. So there are two implications of that. Firstly, there will need to be decisions made about neoadjuvant treatment versus going for this new individualized neoantigen therapy. And I think most clinicians will choose with their patients to have neoadjuvant therapy because of the very striking differences in the randomized trials between neoadjuvant and adjuvant. However, as you mentioned, this would really invigorate a line of investigation to look at neoantigen vaccines in the neoadjuvant therapy as well. If there was additional benefit of personalised neoantigen vaccines on top of what we already are seeing with neoadjuvant therapy, there will be very few relapses for stage 3 melanoma. And as some oncologists have sometimes said when they've looked at data that's very impressive with very few relapses, maybe we'll be done, which is intriguing concept. But no, very important to actually also investigate this neoantigen vaccine approach in a neoadjuvant setting as well.
Thank you, Dr. McArthur, for speaking about the JCO article, Intismeran Autogene plus Pembrolizumab versus Pembrolizumab alone in high-risk resected melanoma, a 5-year update of the randomized phase 2B Keynote 942 study. It's indeed exciting. Please take a moment to rate, review, and subscribe to all ASCO podcast shows at asco.org/podcasts.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.